Welcome, everyone. Thank you for being here today. My name is Roberta Lavin, and I'm excited to share this presentation with you on a topic that is critically important in the field of emergency management and public health nursing: vulnerable populations in disasters. Before we dive into the content, let's take a moment to review our learning objectives for today. And some of these, well, they may be a little more detailed than I put on the syllabus, but don't worry. All the content that need to know is being presented to you. By the end of the presentation, you will be able to first identify the vulnerable populations that are disproportionately affected by disasters. Second, understand social determinants that increase disaster vulnerability. Third, describe the federal resources available to support vulnerable populations. Fourth, explain state and local emergency management systems. Fifth, recognize the contributions of volunteer organizations. And sixth, apply nursing strategies to promote health equity in disaster preparedness and recovery. As with all lectures, please make sure to stop the recording about every 15 minutes. Get up, walk around, give yourself a break, think about what you've learned, and then come back and start again. You learn a lot more that way, and you know how to hit the pause button. So let's start with the foundational question. What exactly do you mean when you talk about vulnerable populations? Vulnerable populations are groups of people who are at increased risk for poor physical, psychological, and social health outcomes during disasters. This vulnerability is not random. It's shaped by a complex set of factors that limit a person's ability to prepare for, respond to, and recover from a disaster. Key characteristics include limited access to resources, functional and access needs, pre-existing health conditions, and social and economic disadvantages. Now, let's look at specific groups that are commonly identified as vulnerable populations. Older adults often have mobility limitations and chronic health conditions. Children and infants are entirely dependent on caregivers. People with disabilities face significant barriers to evacuation and communication. Low-income individuals lack the financial resources to stockpile supplies or evacuate. Racial and ethnic minority groups face systemic inequalities. Individuals with chronic medical conditions face life-threatening risk when care is disrupted. And people who are experiencing homelessness, who are unhoused, and non-English speakers also face extreme challenges. Understanding why disasters disproportionately affect vulnerable populations requires us to look across the phases of disaster. Before a disaster, financial barriers prevent stockpiling supplies. During a disaster, mobility limitations or inaccessibility to shelters become life-threatening. And after a disaster, navigating complex assistance programs can be overwhelming, particularly for those with limited English proficiency or cognitive disabilities. This is why a one-size-fits-all approach to disaster management isn't sufficient. So remember, before the disaster, limited resources and emergency supplies and evacuation, inadequate housing in high-risk areas. During the disaster, difficulty evacuating without assistance, and communication barriers preventing critical information from being delivered. And after the disaster, challenges navigating complex assistance programs and slower recovery due to pre-existing disadvantages. To truly understand disaster vulnerability, we need to look at the social determinants of health. Economic stability is fundamental. Um, Poverty increases risk and slows recovery. Education affects health literacy and the ability to act on emergency instructions. Healthcare access is critical for those who are uninsured. The neighborhood and built environment, such as substandard housing, also matters enormously. Finally, social and community context, including discrimination and isolation, affect resilience. So, the big things: economic stability, education access, healthcare access, neighborhood environment, social context, and we must be addressing these determinants because it is essential to equitable disaster response and recovery. Health equity means that everyone has a fair and just opportunity to maintain their highest level of health. In disasters, this is particularly important because disasters exacerbate existing inequalities. Achieving health equity requires identifying systemic barriers, providing culturally competent services, engaging vulnerable communities in planning, and allocating resources based on need. As nurses, we have a responsibility to advocate for these principles. Health equity requires everyone has a fair opportunity. We know that disasters exacerbate this. We know vulnerable populations experience worse outcomes. We know that recovery is slower. And this requires identifying and addressing the systemic barriers. Equitable resource allocation based on need and not just size. The CMIST framework is a practical tool for functional needs assessment. It stands for communication, medical, independence, supervision, and transportation. Let's walk through it. Communication refers to the ability to receive and understand information. Medical refers to maintaining treatment. Independence refers to daily functioning. Supervision refers to safety support for those with cognitive disabilities. Transportation refers to the ability to evacuate. This framework focuses on functional needs rather than diagnostic categories. So remember, CMIST. Even when people want to prepare, they face significant barriers. Financial barriers are the most significant as supplies and evacuation cost money. Physical barriers affect those with mobility limitations. Cognitive and sensory barriers affect the ability to understand instructions. And social barriers include language differences and distrust of government agencies. Systemic barriers like inaccessible shelters reflect failures at the planning level. There are also barriers in disaster recovery. Recovery is often a long process with unique barriers. Documentation challenges are significant for those who lost IDs or property deeds. Navigation complexity makes it hard to apply for multiple programs. Resource limitations mean that even with assistance, survivors may not fully recover. Healthcare disruption is a critical concern for those with chronic conditions, and understanding these barriers helps us to identify where advocacy is most needed. So remember the barriers to disaster recovery: lack of documentation, so lost IDs, confusing application processes, resources that are insufficient, healthcare when people have been displaced and are away from their regular healthcare providers. And mental health, trauma, loss, and psychological distress. So, psychological and mental health impacts are a real consequence of disaster. Common issues include PTSD, depression, anxiety, grief, and substance abuse. They're at higher risk when it's children, those with pre-existing conditions, and isolated individuals. There is crisis counseling through FEMA programs, and support services address psychological distress for disaster survivors. Disasters do take a significant toll on mental health. I just went through some of the common issues of PTSD, depression, anxiety, and grief. Pre existing conditions may also exacerbate the conditions, diabetes and hypertension. Children, the elderly, and socially isolated are at higher risk. FEMA's Crisis Counseling Assistant and Training Program provides funding for short term services, and nurses should screen all survivors for mental health impacts. Children are particularly vulnerable due to the developmental stage and dependence on caregivers. Disasters disrupt routines and schools. Special considerations include age-appropriate communication, maintaining normalcy, and reunification procedures. Services for children include disaster case management, school-based counseling, and pediatric medical care in shelters. One of the most important things is to try to return children to a state of normalcy as soon as possible, and that means getting them back in school. Older adults face unique vulnerabilities of their own, including chronic health conditions, mobility limitations, and social isolation. They may need assistance with evacuation, accessible shelters, and medication management. Resources include area agencies on aging, Medicare, and senior centers. Nurses should advocate for accessible, age-appropriate services for this population. People with disabilities face significant challenges. These disabilities may be sensory, cognitive, mental, or people may have multiple disabilities. They need information in accessible formats. They need accessible evacuation routes and shelters that accommodate service animals and medical equipment. The American with Disabilities Act requires emergency management programs to be accessible. Nurses can advocate by ensuring patient needs are documented and communicated to responders. Those with chronic conditions face life-threatening risk when care is disrupted. High-risk conditions include dialysis-dependent kidney disease, oxygen-dependent respiratory conditions, and insulin-dependent diabetes. Preparedness requires backup power, extra medication, and a written medical history. Nurses play a critical role in helping these patients develop specific disaster plans. So remember to think about the things that you know as a nurse are high risk: dialysis, oxygen dependency, insulin dependency, cancer treatments, and conditions requiring refrigerated medications. These people are going to need backup power, they're going to need extra medication, and they're going to need you to make sure that they have a good medical history. And then, of course, emergency services have to include prioritizing dialysis centers. Racial and ethnic minority groups experience disproportionate impact due to systemic inequalities and residential segregation. And yes, it still happens. Obviously, not legally, but it happens. Cultural and linguistic barriers, as well as historical distrust of government, create additional challenges. Equitable strategies include multilingual communication, partnering with community organizations, and providing culturally competent outreach. The federal system is anchored by the Stafford Act. When disasters exceed state capacity, a presidential declaration activates federal assistance. This includes individual assistance, public assistance, and hazard mitigation. FEMA is the lead agency coordinating with state, local, and voluntary partners under the National Response Framework. FEMA individual assistance provides direct aid to households. Housing assistance includes temporary rental aid and home repair grants. Other needs assistance covers medical, dental, funeral, and personal property costs. It is intended to meet basic needs, not to make survivors whole. Nurses can help by providing information and encouraging patients to apply. Survivors can also apply online through the government. And I've given you an email address and a phone number, but remember this can change. So if you're ever in an actual disaster, look it up and make sure it's correct. They will need their Social Security number, address, insurance information, and a description of damage. The deadline is typically 60 days from the declaration. Nurses can assist vulnerable individuals with the application and can help gather required documentation. Disaster recovery centers, or often called DRCs, are physical locations where survivors can meet face-to-face with FEMA and the Small Business Administration representatives. They provide help with applications and appeals. All DRCs are required to be ADA accessible and provide language interpretation. For those who struggle with technology, DRCs are a vital lifeline. And then there's transitional sheltering assistance. TSAs provide short-term hotel lodging for displaced survivors. It bridges the gap between emergency shelters and long-term housing. FEMA pays the hotel directly. Nurses should assess whether hotel placements are appropriate and accessible for clients with specific functional needs. The Small Business Administration provides low-interest loans to homeowners and renters, not just businesses. Homeowners can get up to $200,000 for repairs and $40,000 for personal property. Keep in mind these numbers also change over time. So again, you would need to look this up and make sure what the current amount is. These loans have low interest rates and long terms. FEMA may refer survivors to the Small Business Administration as part of their assistance program. HHS is the lead for public health and medical response, coordinating medical teams and supplies. The CDC provides guidance for vulnerable population disease surveillance and health communication. Key programs include the Strategic National Stockpile and hospital preparedness. The CDC provides planning tools like the Social Vulnerability Index to identify at-risk communities. They offer preparedness checklists for people with disabilities and chronic conditions. Their approach is grounded in health equity, ensuring culturally appropriate risk communication and inclusive planning. NDMS, or the National Disaster Medical System, supplements state and local medical capabilities. It includes disaster medical assistance teams made up of medical professionals who provide emergency care in disaster areas. It also coordinates patient movement to unaffected areas when local hospitals are overwhelmed. There are also DMORTs, which are for victim identification and mortuary services. Housing and Urban Development provides community development block grants for disaster recovery. These funds are for long-term rebuilding, targeted at low-income households. They also offer Section 8 vouchers for displaced families and FHA mortgage relief. HUD ensures that housing laws are enforced during disasters. So there's a lot that HUD does or did, and they are critical during disasters. The USDA provides disaster SNAP for temporary food assistance. Let me put an asterisk on this. We all know the current political situation and the problems with SNAP. So again, these are services that have historically existed. They will probably exist again, but right now, on any given day, we do not know what is going to be available and what isn't. So USDA also distributes emergency foods through food banks and provides grants for rural community water systems. For rural homeowners, the Section 502 loan program helps with repairs. The Social Security Administration expedites card replacement and advance payments. The VA provides health care and temporary housing for veterans. The Department of Education offers student loan relief. The Department of Labor provides disaster and employment system for those who lose their jobs due to the disaster. State agencies coordinate response and requests for food aid. Many states have their own disaster relief funds, tax relief, and utility assistance programs. They manage the National Guard and the mutual aid agreement with other states to ensure a comprehensive response. State health departments conduct disease surveillance, environmental health assessments, and medical countermeasure distribution. They provide specific services for vulnerable populations, such as replacement medications and public health nursing and for household individuals. Local emergencies are the first to respond. And they tend to manage their own EOCs. And the local emergency response includes first responders and emergency shelters. Community emergency response teams are CERTs, trained volunteers, and basic skills. Because local knowledge really is critical for reaching vulnerable populations in their own neighborhoods. Local health departments conduct inspections, control outbreaks, and provide public health nursing. They manage the Medical Reserve Corps and conduct outreach to ensure services reach underserved populations. Their established community relationships are invaluable in a disaster. Shelters provide safe refuge, meals, and basic necessities. They are typically operated by the Red Cross. All shelters must be ADA compliant. Some communities establish functional needs shelters for those requiring a higher level of medical support. And nurses provide health assessment and medication management in these shelters. Remember, the purpose of shelters is to be a temporary safe refuge. Operations typically are operated by the Red Cross, and they provide sleeping space, meals, and basic necessities. All of them must be ADA compliant, and there's usually medical support available. Some places have special medical needs shelters. Community-based organizations have trusted relationships with the communities they serve. They provide culturally and linguistically appropriate outreach. They help navigate assistance programs and distribute supplies. Partnering with these community based organizations is essential for reaching populations that may not trust government organizations. Their role is to provide culturally competent care because they're trusted. Um, they may include care for immigrant and refugee services, disability organizations, and senior centers, community health centers, food banks, and cultural associations. The services usually are multilingual, they have navigation assistance, and they have case management. And some of the things they do are direct services, emotional support, and partnership with government. Then there's the 211 information and referral system. 211 is a free helpline for connecting people to community resources such as disaster services. They can connect people to food, housing, and a lot of other things. They're usually accessible 24 hours by phone, text, or online, and they should always be multilingual. 211 is a free helpline, and it does connect people with human services. In a disaster, it provides information on shelters, food assistance, and mental health referrals. It's available 24/7, and it offers multilingual services, serving as a vital link between survivors and resources. So the whole community approach recognizes that government alone cannot meet all needs. It encourages individuals, businesses, and nonprofits to coordinate in planning. For vulnerable populations, this means inclusive planning and community-driven solutions that are more likely to be effective and culturally appropriate. So the whole concept is to engage full capacity of community and emergency management and planning. They understand community diversity, and they recognize the capabilities available in the community. Uh, these are frequently partnerships that are already in place and already built, and so they're inclusive, they're trusted, and they're community driven. The national volunteer organizations active in disaster coordinate the efforts of over 110 member organizations, like the American Red Cross and the Salvation Army. Their model is built on communication, coordination, collaboration, and to ensure a more effective and collective response. So their mission really is communication and coordination with all these massive number of volunteer organizations that are active in disaster. Um, and there are a lot of services that you'll recognize, like the Red Cross, the Salvation Army, the United Way, Catholic Charities, Lutheran Disaster Services, Team Rubicon. And they called their activity the 4 C's: communication, cooperation, collaboration, and coordination. State and local VOADs, so the volunteer organizations active in disaster, often referred to as VOADs, coordinate volunteer and donated goods at the community level. They identify services gaps and establish long-term recovery groups to help survivors rebuild for months or even years after the initial disaster. The Red Cross is the primary partner for FEMA, providing mass care, emergency shelters, and health services. Red Cross nurses provide health assessments and mental health support in shelters, and they also offer preparedness education and financial assistance for immediate needs. Again, the disaster services, they respond to about 60,000 disasters annually. And remember that Red Cross responds to house fires in communities all across the country. They manage these shelters, or a large number of them. They also have nurses that can provide some health services. They do casework and financial assistance and referrals, um, and they do a lot of education. The Salvation Army provides mobile feeding units, emergency shelters, and spiritual care. In the recovery phase, they offer case management, financial assistance for unmet needs, and home repair programs. They also have a strong presence in local communities across the country. Faith communities provide trusted outreach, facilities for shelters, and motivated volunteers. Major organizations like Catholic Charities and Islamic Relief provide disaster case management, financial aid, and long-term recovery support. They are often the first to reach underserved populations. But those are just a few. Remember, major organizations also include Lutheran Disaster Services, Presbyterian Disaster Assistance, the United Methodist Committee on Relief. And all of these provide a lot of food distribution and a lot of spiritual care. Team Rubicon is a veteran-led organization providing well, that was a Freudian slip, but debris removal, home repair, and medical support. Their services are free, focusing on vulnerable populations who cannot afford contractors. Veterans bring specialized skills and a cultural service to disaster response. The Medical Reserve Corps, or MRC, is a national network of local groups and volunteers committed to improving the health, safety, and resilience of their communities. It was established after the 9/11 attacks to provide a way for medical and public health professionals to volunteer their skills during emergencies. MRC units are community-based and function in a way to organize and train local volunteers, including nurses, physicians, pharmacists, and non-medical support staff, to supplement existing emergency and public health resources. When a disaster strikes, MRC volunteers may be called upon to staff shelters, assist with mass vaccinations and medication clinics, provide surge capacity in local hospitals, or conduct wellness checks on vulnerable residents. For nurses, the MRC offers a structured way to contribute. You receive training in the National Incident Management System, the Incident Command System, ensuring you can integrate seamlessly into the professional response. Because the MRC units are local, they are often the first medical volunteers on the scene, and they have the local knowledge necessary to identify where the most vulnerable individuals in the community are located. Albuquerque has an MRC, and you should all think about joining it and looking into it. A critical question in disaster management is, how do all these different groups, FEMA, state agencies, the Red Cross, local churches, actually work together without tripping all over each other? And the answer lies in formal communication. At the heart of this is the Emergency Operations Center. During a disaster, the EOC is the physical or virtual location where government officials and key partners gather to coordinate the response. Most EOCs have a volunteer liaison, or a VOAD seat, where a representative from the volunteer sector sits side by side with the government decision makers. This ensures that if a local shelter needs more food, the government can immediately ask the VOAD partners who have the capacity to provide it. We also use multi-agency resource centers. These are one-stop shops where survivors can access government programs like FEMA and the Small Business Administration, while also meeting with the Salvation Army, for clothes, or the local nonprofit for legal aid. The whole community approach reduces the burden on the survivor who is already traumatized by bridging the resources and bringing them to you in a coordinated fashion. Obviously, there's always challenges, but some of the things to remember is that ESF 6 does mass care and emergency assistance for housing and human services. The volunteer or liaisons have somebody in the EOC. They all coordinate regularly, but they they face challenges. There are different cultures, there are funding issues and liability, and there's always long-term coordination that is ongoing. As we move into the final section of this presentation, I want to focus a little bit on specific responsibilities of nurses. Nursing in a disaster is different from nursing in a stable clinical environment. It requires a shift from individual-centered care to population-centered care. Our primary responsibility is to ensure the safety and health of the community with a prioritized focus on those who cannot help themselves. This involves rapid assessment, triage, and the management of chronic conditions in austere environments. We are often the eyes and ears on the ground, identifying public health threats like waterborne illnesses and mental health crisis before they become widespread outbreaks. Ethically, nurses have a duty to care, but we also have a responsibility to advocate. In a disaster, resources are scarce. Nurses must ensure that resource allocation is equitable and that vulnerable populations who might not have a loud voice in the planning room are not overlooked in the distribution of life-saving aid. So remember, public health does community assessment to identify vulnerable populations. And so one of the things we always want to make sure of as nurses is that we do have roles in public health, developing emergency plans, clinical care, community education, and advocacy. In the preparedness phase, the time before the disaster strikes, the nurse's role is focused on education and planning for our vulnerable patients. This means helping them create a personal disaster plan. Don't just tell a patient to go be prepared. Help them identify exactly how they will evacuate if they don't have a car. Help them create a go bag that includes a 14-day supply of essential medications, copies of prescriptions, and backup batteries for medical devices like nebulizers and oxygen concentrators. Nurses should also encourage patients to join local special need registries if their community offers them. These registries allow emergency responders to know exactly where people with electricity-dependent medical equipment and mobility issues live, so that they can prioritize during an evacuation or power outage. Your role as a nurse is to bridge the gap between generic emergency plan and a patient-specific functional reality. So, your roles can include emergency care, public health, vulnerable population support, chronic disease management, and volunteer deployment. During a response phase, the environment is often chaotic. The nurse's strategy here is adaptability and assessment. Whether you are in a field hospital, a Red Cross shelter, or a community clinic, your first task is to perform a functional needs assessment using the CMIS framework we discussed. In a shelter setting, look for the quiet vulnerabilities. Is there a mother who can't refrigerate her child's insulin? Is there an elder man who is becoming disoriented because he lost his hearing aids in the flood? Nurses also provide psychological first aid. This isn't therapy. It's about providing a calm presence. helping people meet their basic needs and connecting them with their loved ones. By stabilizing the immediate physical and emotional needs of vulnerable survivors, you prevent long term complications and help maintain order and safety in the response. So, again, your roles can be case management, service coordination, home health, mental health, and long term monitoring. Recovery is the longest phase of a disaster and often lasts years. For vulnerable populations, the disaster after the disaster is the struggle to navigate the bureaucracy of recovery. Nurses serve as vital case managers and navigators during this time. We must, we must monitor for delayed health impacts such as mold related respiratory issues in flooded homes or the worsening of chronic disease, uh, like hypertension due to prolonged stress. We also need to be vigilant about mental health. The adrenaline of the response phase wears off, leaving survivors to face the reality of their losses. Nurses should help patients connect with their long term resources that we've discussed: FEMA appeals, the Small Business Administration loans, and VOAD rebuilding programs. Our goal is recovery. It's not just to return the patients to their pre existing disaster state, but to help them build back more resiliently, address the social determinants that made them vulnerable in the first place. So, again, what are your roles? Inclusive planning, conducting community assessments, accessible communication, accessible services, and resource allocation. As we conclude, I want to leave you with a call to action. Advocacy, health equity, and disasters doesn't happen by accident. It happens because health professionals demand it. Advocacy means participating in your local emergency planning committee to ensure that shelters plans include bariatric cots, ASL interpreters, um, culturally appropriate food. It means pushing for emergency alerts to be sent in multiple language. It means ensuring that whole community planning actually includes representatives from the community being planned for. When you see a gap, when you see a policy that inadvertently excludes a group of people, speak up. Your clinical expertise gives you a powerful voice in the policy arena. Use it. Use it to ensure that the most vulnerable among us are the most protected when the next storm comes. So remember uh, that cultural competence in a disaster is important for you. Um, you need the ability to understand and interact effectively across cultures. This matters. It builds trust, it improves communication, and it increases service use. We need workforce diversity. Recruit bilingual, bicultural staff and provide training. We need community partnerships that cut across cultural organizations and engage leaders. Um, we've covered a lot of ground today. And from federal programs of FEMA and HHS to the local efforts of the Medical Reserve Corps and faith based volunteer organizations, we've explored the systemic roots of vulnerability and the practical strategies nurses can use to promote equity. The key takeaway is that disaster management is a team sport. Not a single agency, not one, can do it alone. By understanding the landscape of resources and their unique roles as nurses, we can ensure that our communities are not just surviving disasters, but recovering with dignity and equity. I want to thank you for your time and your commitment to this vital work. At this time, I want you to know My office hours are available. And if you have any questions, please reach out. Thank you again.